Let's start with the basics. What's the goal of autotransfusion? The goal of autotransfusion is to return the highest quantity and quality of red blood cells to patients with the least amount of waste as quickly as possible. Take a look at what goes on inside an autotransfusion device. There are three categorically different methods of blood processing: passive cell salvage, which uses a Latham bowl, continuous cell salvage, and dynamic cell salvage, which is available only in the Autolog IQ. Dynamic cell salvage uses algorithm-driven intelligent blood sensing to make micro-adjustments during processing in order to recover high-quality blood fast, automatically. How does it work? There are three things that distinguish dynamic cell salvage. First, there's the IntelliPath bowl. One bowl size works for most procedures. That may seem counterintuitive, but it's designed to work that way very effectively. Now here's where it gets really interesting. The Autolog IQ uses an adaptive two-stage fill process to get high hematocrit with less waste. It's a little like filling a soda glass. Pour it in all at once, and you know what happens. With the adaptive two-stage fill, the system does an initial fill. It pauses briefly to compact the red blood cells. Then it adjusts the second fill speed, slower for low hematocrit, faster for high. That way you keep more red blood cells and lose less into the waste bag. The third key feature is the pulse wash. See these little indentations? They are part of the IntelliPath bowl design. They disrupt the red blood cell pack during the wash, which helps optimize saline penetration for an effective wash cycle. The pulse wash makes the wash process more efficient by adjusting the saline volume, depending on the characteristics of the red blood cell pack. Each pulse volume is designed to help minimize red blood cell spillage. All this happens automatically. With the push of a button, you're providing high hematocrit and quality-packed red blood cells for the patient with just one program. You might think that this intelligently calibrated process would be slower. Not so. The Autolog IQ processing rate is approximately 3 minutes. Every now and then, you may have an exceptional case where you want to override the automated setting. No problem. Just press the setting you want for immediate override. The Autolog IQ system consistently delivers high-quality blood product automatically. Simply genius.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Hello and welcome to PerfWeb 27. I almost got all of my work done. I am your humble host, Joe Basha, and I want to welcome all of you here to day one. We have 3 days of PerfWeb 27. And we've got a great show, I think, for you today. I'm really excited about it. So let's go over the social media first. That's right. So obligatorily, we are streaming to Facebook. We are streaming to the Twitter, to YouTube. We have the LinkedIn now new, so you can go to any of the. Where's the LinkedIn logo? Haven't seen it. Oh, it is. Oh, okay. You got to make sure that you share, you like us on Facebook, right? Share us on the Twitter, make sure that you subscribe to the YouTube, and then there it is, and then also do the new link in. So there it is right there. So I don't know, do we have the, like, how do they find that stuff?
Perfusion Education.
Oh, you go to perfusioneducation.com and you click on the social media icon that you want, and there you go. We also have the call-in number if you want to call and discuss anything today. There's the telephone number. The phone sits right here. You can be live on the air, and would love to hear from you, get your opinion, get your questions. If you're looking on Facebook, now look, I can only monitor one thing at a time, so I monitor the YouTube channel, but if you are on Facebook or you're on the Twitter or LinkedIn or whatever it is you're on, keep that number, call. It's always easier for us, although you can do the chat, but I'm only monitoring the YouTube. I can't monitor all three of them myself, and we just don't have enough staff yet to do it. So I guess we all need computers, and then we all just pick one, and we'll go from there. So I've got a great faculty with us today. Immediately to my right here is, of course, Tammy Sparacino. You've all met her before. Hello, Tammy.
Hi.
And she's a THI grad from 2003, has done her work here in the local Houston area. At just a couple of hospitals, THI, of course, Mem City, Memorial City. Where else? What other hospitals were you at?
VA, Ben Taub.
VA, Ben Taub, the trauma center of the South.
MD Anderson.
MD Anderson. That's like Ben Taub is like the charity hospital of New Orleans. Yeah, MD Anderson, so quite a few. It's quite a breadth of experience. And then, of course, we have right next to her, you've all met Katie Kim before. Katie graduated from the Medical University of South Carolina, where received her BSN in 2007. And then she received her master's in nursing in 2018 from Grand Canyon University. She's previously been with CHI St. Luke's hospitals. And she is currently the Director of Education for our MediWeb and Guardia Nurse ECMO Specialist Training, and for HET and a variety of other companies. So she's got a whole bunch of different things. But welcome, Katie. Nice to see you again.
Thank you.
And then next to her is Mike Brown. Mike is a 1982 graduate of the Texas Heart Institute. And he has spent your career also here in Houston, working at a lot of the same hospitals as Tammy. You've been down to Ben Taub. I think you also went to Texas Children's. You've been in the Woodlands, a lot of that area, the Springs, Cypress, and the community hospitals, but level 2 trauma center places. So you've got a lot of experience there with you too. And welcome back. You've been with our program a couple of times. It's great to see you again. And of course, then there was Patrick. And here comes Patrick. Patrick, come on, Patrick, do a little dance for us. Okay.
Traffic issues.
Thank you. And then there's Patrick, and he's a 1996 graduate from Rush, and he spent about 12, 14 years in perfusion, then got out, was in industry for a short period of time, and has recently come back to perfusion, been back in for about 4 or 5 years now, maybe even 6. I don't know how long exactly. 5. And has done an outstanding job, really big, very big on ECMO. And in fact, my talk, I think you're going to really enjoy today because I talk about that. And then coming in via Skype, we have Rodger DeLong, and Rodger graduated from Barry University in 1991. He practiced until 2012. In fact, a lot of us know Rodger DeLong. You know, Rodger's fairly well known in our industry. But then he went to industry and did some work with a company, Transonic, for a number of years, and now is coming back to clinical practice, but spent the last 6 years or so as a clinical consultant as opposed to a clinical practitioner. So he's still been very much involved. And this first talk that he's going to give, I've actually heard this talk before. How this whole thing happened was, we were at THI, you were there with me, and we were watching from Texas Heart. It was during the Cooley lectures, I guess, or the for the students and stuff. And this guy, Rodger gets up there. And of course, you know Rodger too. You've met him before. I've met him. So I was like, I wonder what he's going to talk about. He gives this talk, and I was like, I have got to have this guy come down here and give this talk. So welcome to everyone here and in the studio with me. Rodger, thank you so much for coming to us via Skype. I'm not exactly sure where you are, but please feel free. The floor is yours, and your presentation is loaded up. Just let us know when you're ready to go.
Well, ready to go now.
And welcome to all of you out there in Web World who are watching, so thank you very much.
All right, Joe, thank you for all the kind words. It's very nice to be here. All right, can you see the screen?
Yes, but your voice is a little bit crackly.
All righty. In my recent experience as a clinical specialist, I had the pleasure of being in a lot of ICU units and looking at a lot of ECMO difficulties they were having. And I was kind of surprised to see how variable some of their assessments were. Some were impressively aggressive, some lesser so. But the bare question we get down to is the amount of clot in an oxygenator has traditionally just been impossible to determine. And I thought I'd go over a few of the things that we use currently that help us to find out just how much there is. Next slide. Joe, I think he has control of the slides, right?
Yes, yeah. It just takes a second for you to see it.
All right.
You have it?
I'm not seeing what you're seeing on the screen.
What's going on, guys? Hold on. Time out, everybody. Oh, he exited out of it. Oh, let me call him. Oh, here. Oh, okay. We'll call him. That was for a special event, not a lifetime. There we go. Hey, Roger. Welcome back.
All right. Sorry about that.
That's okay. I think there may be some reason you should be able to see the slides because they're up now.
All right. I'll do my best with what I can see. It's kind of small.
Well, wait. David can help you make them big.
I got it. That's okay. All righty. Let's start back at the beginning, going through some of the coagulation difficulties. In perfusion school, we learned all about the different, about the coagulation tree, intrinsic, extrinsic, common, all the elements within. Next slide. And with that, all the anticoagulants and how they involve the different levels, the different steps. Next slide. And on to the propagation phases, et cetera, et cetera. We learned all about the cascade, but we weren't given many tools on evaluating how much we've gotten. Go ahead, next slide. Everyone measures the different amounts of more or less of the different blood gases. Everyone's using ACTs and PTTs largely replaced with APTTs. Some use the anti-factor 10 thromboelastographs, rotational thromboelastometry. Both of those are still kind of hotly debated in some places. The AT3 levels, fibrinogen with how many strands of fibers we're getting, the D-dimer showing how many strand pieces are breaking up. All of them can be useful in their own way to show the propensity and the degree, but none of them have any clue as to the volumes we've got within the circuit, within the oxygenator. Next slide. All right, so what are the problems we're facing on ECMO? Well, let's start with the basic anticoagulation we all understand. The CPB is not handled the same as ECMO. Next slide. In the early 60s, we determined the heparin dose response curve, and you can see the ACT here versus the percent of effectiveness at the different levels of heparin. Next slide. At a level of about 300, will effectively anticoagulate about well over 90% of the population. The safety factors were added to that of 33 and 60%. Next slide. And showing here at 60% over top of the other number, that's where the common number of 480 comes from. It's nothing more scientific than that. Next slide. But in the world of ECMO, similar to the cath lab, we're dealing with ACTs of 180 to 200. The cath lab, you get away with it. You've got a wire. It's in place for an hour. But on ECMO, you're in there for weeks, if not months. So we're virtually assuring that there's going to be clot constantly growing within all of the patients. Next slide. All right. The rates vary. There's no consistency. I've seen oxygenators get changed out within 3 days. I've heard of them getting changed out within 1. Some people go a month or more without any change outs at all. So there's no good determinable rate that we can even predict that they're going to clot. Next. All right. Additionally, you can only see clot within a few millimeters of the plastic, and even then, only if it's a different color. You can't tell if there's any inside the fibers, and you can't even really see even large ones if they're under the plastic and the color is the same. Next. So there's really no reliable assay available that we can say, okay, that's enough clot. We need to do something. So with all that in mind, next slide, the question is, how do we know when an oxygenator should be changed out? And that's a big problem. Like I said, I've seen a lot of places that don't use nearly all the tools that are available, but they all seem to do a pretty good job, or not. We'll talk about that in a second. Next. So let's briefly go over all the things that I know of today that we could possibly use and are being used to determine what amount of clot you're getting in the oxygenator. I'm not addressing the circuit specifically because clot traditionally isn't found in the circuit, possibly around the rims of some of the fittings, the connectors, but the clots are generally the largest amount is where the flow is slowest and there's a lot of surface area to grab onto, and that's going to be in the fibers of the oxygenator. The first thing we use, and it's a lot of fun, you darken the room and you get on your knees and you hunt around with an oblique light with a flashlight. Next slide. Really sharp-eyed people get down in there close and they can try and see if there's any clots, anything moving, anything holding still. Next slide. In this one, there's a tiny little amount. There's 5 different flecks that you can barely see. Okay, I see the flecks. Now what do I do with that information? Not very quantitative. Next. All right. Coagulation testing we've already discussed. You have the whole realm of testing that can be done. Next slide. These are the same list that we showed before. They're all valuable in their own way, used at different times by different intensivists, preferred at different institutions. But again, none of them relate to the volume that's lying within the oxygenator. Next. Pressure differential. By that I'm talking about the pressure pre and post oxygenator. Universally, if you only do one test, this is the one. The idea of this is as clot grows, resistance grows, and the pressure will grow. And if the pressure grows enough, you change out the oxygenator. Unfortunately, there's a lot of evidence kind of condemning this process. Next. Next. All right, here's an oxygenator that was rinsed out, and it had a nice layer of soft clot. The oxygenators will be talking to some apologies to McKay. Generally, they produce some pretty good equipment, but well over 95% of all the ECMO units are using the Quadrox, one of the models of Quadrox. So we'll be discussing this one primarily, but the problems I'm discussing also are pertinent with cylindrical oxygenators. But let's have fun with the Quadrox here. Here's a nice soft clot that's growing universally across the face. And that's the assumption that is generally made. They say, well, if the clot grows uniformly across the face, the pressure will rise in a linear fashion, and I'll get a pretty predictable number with high reliability of how much clot I have. Next picture. This is a little more common. This is a lot more common. The Quadrox has corners. Any engineer that decided to put corners on a hydrodynamic system, in this case hemodynamic system, must have been banging his fist on the table saying, guys, we can't do that. At least I hope they did, because there's no rationale for corners. And this would be a good reason why. the flow is inevitably going to be slower in the corners. And this is a pretty typical shot where you've got some well-developed clot in the corners, and it varies throughout the face. Next slide. You can also see a small portion here with fairly wide open fibers. These act much like a leak in any system, and the pressures will be deceptively lower. They won't rise if you even have a small field of open fibers. Next one. All right, here you have something that looked very nice on the upstream side, but somewhere inside there's a large amount of clots that were growing through the fibers, and you can see the mature nodules, if you will, that were growing until the flow had enough surface area to knock it off, and then onto the patient it goes. Also with this, you can notice a lot of wide open fiber fields. There's no upstream indicator pressure-wise that this would be a problem. Next one. This is a nightmare situation. You've got a huge amount of mature clot. Like the last one, this is the downstream side of the oxygenator. Wide open fields of nice fresh fibers. There's no upstream indication that there's any problem. Downstream, you've got a mountain of clot that's growing and breaking and sloughing off. And the case report that came with this, I was told that the baby died in a little over a week from a stroke on VA ECMO. Next picture. All right, this is kind of easy to understand if you look at the basic pressure flow curves that we've seen. The Reed curve shows the amount of increasing blockage across the bottom from 0 to 100, and yet the red line will show you that the flow will remain fine up to about 70–75%, and that's not coincidentally why cath labs don't refer lesions for surgery until they're about that high, because you can sustain 100% flow through lesions that large. Next picture. So you got a lot of a drop in that later period, and this is inversely, the flow is inversely proportional to pressure. So you would have a mirror image steep incline only as a late sign in the oxygenator.
It's completely dead. Good. Okay. Mm-hmm.
Okay, we're back on Facebook. Let me see.
We're back on Facebook. Okay, good. You're getting as bad as me. All right, but are we on the tweeter?
Give me a second.
Okay, don't forget, turn your camera back on, Roger. Everybody laughs at me when I call it the tweeter. They keep trying to convince me it's Twitter, but that would mean that you send Twitters. You'd send tweets. You don't send twits.
Oh, jeez.
Right? Doesn't that make sense?
It makes sense. Yeah, it's not correct.
It doesn't matter. It's correct to me.
Makes sense.
Hey, we're back up. Okay.
No,
No, not yet. We're not quite yet. Not quite there. We have to go. Now we have to go live.
yes, we are live.
Okay.
We're live. Okay. Welcome back, everyone. And please forgive us. We had just a minor technical difficulty, but it's all been fixed by the expert broadcasting crew over there. So we're good now. Roger, please forgive us for the interruption. Continue.
I've got a glitch at my end now.
No, that doesn't.
Yeah, you guys are like a still shot. I'm not getting that.
Oh, we see you. You're perfect. And we see your slides.
We are on the last slide. So.
Mm-hmm.
Yeah, if you back up one, that'd be better. I don't have a live shot of you. I just get a still shot. I don't know how to fix that.
Yeah, that's okay. Don't worry about that.
Well, I need it before I can see the slides.
Oh, you need us. Oh, okay. Oh, I didn't know you couldn't see the slides.
All right, nothing is working here. I'm going to hang up and call. Can you call back on Skype?
Yeah, sure.
Okay.
How you been, Mike? I haven't seen you for a while.
Pretty tough.
I'm right there. I'm getting close.
What? But it wasn't the first. Okay, I'd like to hear about that. Not while on the internet. Yeah. I think we're live. We're still live.
What's up? What's happening?
You want to pick up? He's not picking up.
Da 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 da. I mean, just call him on his phone and tell him. Can you just talk to him and just tell him what to do?
Yeah, just make sense.
Oh, really?
Are we online?
Is tomorrow the last day?
Oh, okay. We'll go to a wide shot of us. Hey, everybody. Okay, so we're just having some technical difficulties, and it's part of this process. I wish it was easier, and I wish these things didn't happen, but they do. But we're here where we are. So let's see. I guess what can we do? Patrick, tell us about your case today. What'd you do?
It was a pretty straightforward case. It was a 3-vessel bypass with Mark Matoyer, who we work with all the time, and it was easy. It was a good day. But then there was several other emergencies around town, and so what happened is during the I had to do part of the second case, which was fine. Not what I expected, but it was fun to help out in a tough situation.
Good, excellent. Hey, how did your case go the other day, that high-risk case in the cath lab where they were doing ECMO standby? Oh, we're back? Oh, okay.
I got this. Sorry about that.
That's it. Listen, don't worry about it. It's okay.
All right. You want to back up one slide, and then we'll go forward? Okay. Okay, yeah, the next one. Forward. All righty. We'll start from there, Joe.
All right. That sounds perfect. We're ready.
Okay. Across the bottom, you can see the percent of occlusion. This would be true whether it's a vessel, an oxygenator, anything. A garden hose, it doesn't matter. The red line shows the performance of flow as the occlusion increases. And you only have a steep falling off once you get up around the 75–80% range. Next picture. This late end would also be inversely proportional to the occlusion you would see, the pressure you would see upstream from the oxygenator. So by the time you do see an upstream pressure rise, often you've got way too much clot to handle. The first time I was made to realize this by washing out oxygenators and looking at them, I was pretty taken aback. So my reaction was kind of the same as a lot of perfusionists when they see this. Next picture.
Well, this got my attention.
Yeah, it's about right. Next picture. All right. So, the fourth method here is dilution measurement. Next picture. It's a device that I was familiar with. It has an arterial and venous sensor. Same flow sensors that are on the majority of heart-lung machines around the country. The difference with this is a regular sensor can measure instantaneous flow. This monitor totalizes. It'll take a time run and give you the amount of volume between time A and time B. Next picture. All right, and here's the injection port, and it's just a room temperature saline upstream, and the arterial sensor just downstream from the oxygenator. Oh, thank you. Right? Next picture. Well, not next picture. Make it run. Here you can see the injection of saline. It moves through. Now the sensor senses the increase of speed, and that's time 0. The saline bolus moves through the oxygenator, through the line, and as soon as it crosses into the arterial sensor, then it takes the mean of that. So it knows the time between those 2 points, and it knows the total flow between those 2 points. Therefore, between the syringe and the sensor, it knows that volume. And as time goes on and clot grows, volume decreases. It's kind of a low-tech solution, but it's a really good application. Of interest here, also, since there's a venous sensor, it can also track, if you're on VV ECMO, say you've got the saline bolus moves into the patient, whatever percent of that bolus comes immediately out of the patient would also be recorded, and you can figure out the recirculation from that immediately and accurately. Any of you have had intensivists scratching their heads desperately trying to decide if they got to return a patient to an OR or let them be or move the cannulas again, can realize this is it's a very frustrating situation. Same device, just 2 different uses of it. Next picture. Okay, next. All right, the first spike is the bolus, the increase of speed, that's time 0. Next. And then the waveform, that's the saline bolus as it passes through the sensor. All right, next shot. All right, and then you can read directly the oxygenator volume, both percentage and total cc's. Pretty usable bedside. You can move it to different patients. It's there's no other way to get a direct measurement. Next picture. It's one problem with it is it's only a snapshot. Each time you make an injection, it takes 1 point, but it will trend over time. Here you can see in time, I think it's in the 80-hour range, the oxygenator was failing, and they replaced it, and that brought it up to baseline. Next shot. All right. The next one is one I accidentally stumbled across. This is measuring the CO2 output in an oxygenator. Go ahead. There's a Dr. Kessler from Aachen, Germany, wanted to do a study where he correlated how much clot in an oxygenator would correlate with some other factors, the pre and post pressures being one, and also some CO2. This was a new paper, January this year. Next slide. What he did was he took several quadroxes, he drilled little holes in the corner where clot is most likely, and he filled it up with varying amounts of silicone. I think 30, 40, 50, 65, and 85 cc's. And in the bottom, then what he did is he took a CT scan of each one. Now, silicone's, it's more cohesive and adhesive than a blood clot. Blood clot would have more of a diffuse, with more tentacles, fiber, shapes, etc. However, the point would be, this in a single lump form, you can see pretty readily that some of these percentages can show a lot of clot within the fibers and not even be visible. If we took just the fourth one, the 65 cc one, and looked at that, next slide. 65 cc's is 30% of 215 cc, so 30% of this oxygenator is full of clot. Assuming there's blood going through, you would see from the face how little is visible, if at all, in the lower corner. On cross-section, you can see most of the clots inside the oxygenator, so that wouldn't be visible at all downstream, and however small amount upstream. Next. These are the curves, the results. The upper curve is 5 liters per minute flow, middle curve is 2.5 liters, and the lower curve is half a liter, more of a typical pediatric flow. If we look at the 65 cc point, go ahead, we can see that the curves are all pretty well flat right up to that point. At 5 liters of flow, you will start to see it. After the oxygenator is a third full, you will start to see some damming and some upstream pressures jumping. Middle flow a little bit. Troubling to the pediatric perfusionist here, if you're running 500 cc's in this case, even beyond that to the 85 and beyond, you're not going to see a rise in pressure upstream. So the late sign won't occur until significantly later. Next. And next. One curve that he did have on this paper, but for some reason, he doesn't really explain why, he put a CO2 monitor on the gas output of the oxygenator. I had a discussion with Joe earlier about this. The one remarkable thing is all 3 flow rates, they're all fairly linear. They don't vary very much. There's a little hump in the middle, but for single tests like he did, he came up with some pretty linear numbers. Counterintuitive is CO2 drops. Joe and I had a discussion about this, and we shared the idea that sure enough, the CO2 would climb within the patient, but very likely would drop on the exit ramp on the oxygenator. The point being, if you could monitor the CO2 output on an oxygenator, and any respiratory therapist can grab you a simple, cheap monitor to be able to do that, that may be a usable method to measure the clot. You'd have to parallel it with something effective, bench tests, etc. But once you had those numbers in hand, this might become an effective thing. So if you have any perfusion students or fellows that are looking for good things to do a study on, this might be a good inexpensive one to do. Next. All right, the last one is a transcranial Doppler. Next. I went to Johns Hopkins. They have a very talented neuroscience guy, a stroke guy, who's got, I think he's 26, 28 papers he's done, 2 years of a fellowship at Cleveland Clinic, and he's been at Hopkins about 2.5 years, Dr. Cho. This paper, actually more of a case study, came out in January of this year. He's been looking at strokes for all different types of invasive procedures. Recently, he's done papers on TAVRs and VADs with a positive correlation with an increase of microembolic signals with the increasing duration of the ECMO of the procedures. In this case, they had a heart transplant patient who wasn't doing well. They put him on ECMO. Next slide. And he, the upper screen is from the measurement he did the night that they were having trouble. The next day, they replaced the oxygenator, and that was the second test he got. So clearly, that's what you would expect. So anything outside of that, certainly not a welcome thing in your brain. We tend to deal a lot with just tubings and circuits and pressures and flows, but we don't directly address, other than the NIRS, which some people call a random number generator, we don't really look at functions perfusion-wise in the brain.
That's true.
I thought this was a pretty smart thing to be able to do, because after all, it's what we're trying to do the most, is protect not just the patient's organs, but most importantly, the brain. And this reading is taken right off the middle cerebral artery, so he's getting quite accurate information that something's going on there. So are we doing the right thing by anticoagulating patients? We're trading possible cerebral hemorrhaging for known cerebral microemboli. Is our tipping point at 180 to 200 seconds a good one? The jury's still out, but studies like this will go a long way to making some headway for it. Next slide. So those are all the tests kind of rounded up. The flashlight test, a lot of fun to do, but not much use. The coagulation, well, that's going to continue to be used because it does give a lot of indicators for other things, but not so much for clotting. The pressure differential, so a lot.
Putting the Grigri on me. I think she's she might be mad because I was upset because
Somewhere hitting her, damn it, doll.
Facebook is live. Hi everybody on Facebook. We're having again technical difficulties. I'd like to blame it on weather, but I can't. I'd like to blame it on I'm just so good looking that the machine can't handle it, but I guess I can't really do that either. We can blame it on Patrick because he was late. That's always suitable. Somebody's got to take the fall, dude. I like your yellow tie. It's very pretty.
Do you know what this is?
I can't see from here.
It's termite season. And
Termites.
you being from the area that you live.
Yeah, we have a lot of termites in Louisiana.
They fly out in the summer this time of year,
Yeah.
and then they, if they land in water and near wood, I guess they make a new queen.
Yeah. Oh,
So,
wow.
Anyway, I've got a story behind that. You want to hear it?
Sure.
We're just wasting
Sure.
time? All right. So when I lived in New Orleans, and oh, by the way, they told us when we moved into the neighborhood, they said, that day when this all happens, when the humidity's perfect and the temperature is right and these things start swarming out, turn off every light in your house, even your clock radio. Don't even have a clock on. Like, it's got to be dark because these things are so attracted to light, they're going to come into your house. It's going to be terrible. So just do that. So the night that happened, we did that, and then I was going for a walk, and there was a tourist who was wearing these beads that were flashing and they were lighting, and these moths were like these termites were like all over this person. They're going, what is with these moths? And I decided, I'll just let him go ahead and deal with that. So
That was
I didn't
mean,
tell him
dude.
to turn the lights off.
That was not nice. Okay.
Sometimes the tourists in New Orleans aren't so
Come on. You were a tourist once.
Yeah, once. And then I lived there.
Yeah. But you were at least a tourist for a while.
Yeah.
When you first moved there. Yeah. So how are we looking?
We're live.
We're live again? We're back up?
Oh,
Okay.
everybody heard that story?
Hey, so now we got to get his slides up. And
I
we're
think he's just on the last slide.
I know.
Yeah.
And let's try to just hope we get through it now. And Maybe don't go to LinkedIn. I still think you ought to try not to. And this could be the tweeter. I think this is a conspiracy.
You gonna blame it on the tweeter?
Yeah, I think this is a conspiracy.
This is fault of Donald Trump.
I think I think this is Perfusion.com is sabotaging us somehow. I think they're hacking in. Have you got cooling the room down more?
Maybe.
Yeah.
We're up. He can go.
We're up. Okay. All right, Rodger, go ahead. We need to call that Michael Chen guy that has the cyber war. I think that's what's wrong. The Chinese have hacked us.
Oh, no. All right. Well, to summarize, we already talked about the flashlight test and how much fun that is, and coagulation testing, which will continue, neither of which are very quantitative. The pressure differential, I'm sure, will continue to be used and trusted by most people, but it's horribly misleading. I would advise anybody doing this to start cutting the oxygenator out of the circuit before they trash it and rinse it out. I think you'd be pretty surprised at the variability of patterns. It's incredible when you first see the first view. Fourth, the dilution measurement. It's accurate, it's effective. It's a snapshot. You need to run it as a trend every 4, 8, 12, however many hours, but it is useful. The oxygenator CO2 output, well, the jury's still out on that. It will require a good study or two, but that might be something within arm's reach that would also be useful to anybody. And the transcranial Doppler, I'm excited about that. Hopkins is paying full attention. They've got a full-blown study going on that now. So I expect that to turn into a pretty interesting research paper within the next year or so. And that's pretty much all we have. Next slide. If any questions you have, I'll be glad to entertain them.
I'm going to give you applause on that. Yeah, because despite all of the technical difficulties, and I know that was challenging, can we see him as well on the screen? Or yeah, there he goes. I just thought it was a great talk, and I feel bad, frankly, that it had those issues, because it is a great talk, and we feel like you didn't do you good justice there. And probably the best thing to do is to invite you back and have you come to the studio and do it from here. We seem to have fewer complications when we do that. We seem to it always seems to have a problem when we're doing these, even though we think we have all the technology in the world. But be that as it may, I have a bunch of questions, but I'm going to defer over to Tammy because she was writing prolifically over here. So let's go with some of your questions. If anybody's got a call, the phone's open, so if somebody wants to call in, we'll go ahead and put the phone lines up, and we'll let them call in, and I can answer the call. Be patient, though, because I might have to put you on hold till we're ready to talk to you. So go ahead.
Okay, so I have a couple questions. First off, I'm really interested in this dilution measurement. Have you had an opportunity to use that type of thing, or is it just something that you've read about?
Well, until recently, I was working with that at Transonic.
Okay.
So I've seen it bench tested. It's really accurate. It's a good device.
Is that its main purpose? That's why it was created?
Yes. Yeah, there's a research scientist there that's taken the flow measurement sensors and moved them one generation farther into being able to totalize the volume. The interesting thing is we have dilution theory before from things like Swan-Ganz catheters, but dilution isn't very good. It's not thorough, and even though a thermistor reacts quickly, the transit time through the lungs is too fast. So that's why Swan-Ganz catheters can kind of give dilution a bad name. They can be 20, 30, 40% inaccurate. And physicians know this, but it's what they've used, it's what they know, it's what they have. The dilution this uses, the fluid mixes very quickly, and saline is a largely different wavelength than blood, so it reads it pretty accurately.
Mm-hmm. I think that's really promising technology, and it seems like it's smaller type device that really could be used for a great safety for ECMO. There's not a lot of safety devices that really provide useful information.
Yeah, our air sensors aren't going to pick it up.
Right.
You can have an air sensor on there, and that's only going to protect you from air. So Rodger, I like that you talked about that. You mind if I add to the question?
Please.
And my interest in it is more in the recirculation problem with the cannula.
That's.
You kind of went over it, but can you elaborate on that a little bit?
I've got a similar but separate talk on completely on the recirculation aspect. There's been some good papers showing just minor adjustments with, most places are using Avalon or Origin catheters. It's a 2-in-1,
Yeah.
a dual lumen.
Or the Crescent
Or
now.
the Crescent. Yeah.
The Crescent's new. They actually used this device to bench test it in Ann Arbor, Michigan. But the Crescent is longer, and they brag about it not being any recirculation, but that's because it's like inches different from the ports, and they feed it up through the valve. And the problem I see with those is it causes a lot of abrasion on the valve. Yeah, it's going right through into the pulmonary artery.
No,
And
you're talking about that's the tandem heart. That's the Protect Duo. The Crescent is basically the same as the Avalon. It's just, so I guess their patent must have run out. I don't know, but it's a dual lumen that goes into the IVC, so it goes through the IJ, or some people are putting it in the left subclavian and putting it all the way down that way. So it's not the one that goes into the pulmonary artery.
Oh, okay. There's a new one by Medtronic's carrying it for MC3 Labs. That's Bob Bartlett's group. That's the one I thought you meant. The only two that I've seen are the Origin and the Avalon. And the problem with them, if you ever get them in your hands, most places use it, even though it's more expensive. They're several $100s. But the average pediatric ECMO case runs over $300,000. So there's a lot more money available to those groups than there are in cardiac surgery. They got to beg and borrow for the least little thing because the money has drifted over to the cath labs. But in ECMO, they generally can get more that they need. The problem with those dual lumen catheters is if you ever get them in your hand, the proximal and the distal ports are millimeters apart. And if you don't place it perfectly, there's 6 sizes of the Avalon, 7 of the Origin, or vice versa. There's a million sizes of patients. And if the anatomy isn't just right, or they put it a little too far, a little too close, there's a lot of trouble with it spinning around in the atrium until it goes back into the point of least resistance is the distal ports, where it's going to suck it all back into the circuit without the body being able to use it.
So do you have that talk now? I'd almost rather you gave that talk than me give mine, but I'll give mine but you got to promise you're going to give that talk, because I have a real interest in this.
If you want to, I'd be glad to. Sure.
I'd love for you to. No, seriously, if you want to give it now, you can give it now.
I don't have it on the computer right here.
Okay, all right, but that'd be fine with us. So, but that's where my real interest lies. How, I noticed you said that the percent of occlusion, for measuring pressures, because I'm not an advocate of measuring pressures. I'm not an advocate of having a manifold. I'm not an advocate of any of that stuff, but for different reasons. This is yet now another reason why I feel I don't want those things. But what percentage, what's the most sensitive, or what's the sensitivity rather, I guess, of using the transonic device for measuring the clot burden? In other words, when do you start seeing really a difference?
From bench testing, they can put precise amounts of solids into an oxygenator and compare it. The advertised accuracy is within 10%, but that's a very conservatively high percentage. It'll read a lot tighter than that.
Really? So you feel pretty confident in the device. And of course, I'm really also fascinated with the end-tidal CO2. Let me just ask you, do you think we should be using TCD on all ECMO patients as a routine standard of care, continuously?
It's interesting you say that. Most of the Dopplers you see are only instantaneous. Like the one I showed you, that was just I think a 30-second reading. They do have continuous ones, and yeah, that would. I think that Dr. Cho, whatever his results come up to be, I think it's going to be a groundbreaking study.
Yeah.
Because we don't get to see what's going through the brain.
That's right.
We don't really get to see what's going through the circuit.
Well, it's not just and it's not just the
It's not just the brain.
clot. It's but not also yes, but it's true. But I mean, that's big. It's a big deal. But it's not just the clot worrying about embolic events, but flow. It validates so much because if you're not perfusing the brain, it doesn't matter what else you're perfusing. I think. I mean, that's kind of how I feel about it. You know, so I don't know. That's my feeling. Let's go on down. Questions, Miss Katie Kim?
Yes, I was wondering, does it measure the volume that's moving through the oxygenator or measuring the volume of the clot itself?
It's by deduction, you know the clot. It's measuring when the saline goes in to when it leaves. So if you fill up some of that space, then it's not liquid anymore. So a 250 cc oxygenator, if there's 30 cc's of clot, well, then it's going to go through that much faster.
Okay, so it's measuring speed.
It's low tech. It'll read it'll read the volume directly.
So is it reading velocity? Is it just reading transit time? I mean, what is it actually measuring?
It's measuring all the flow between time zero and when the different wavelength fluid saline goes through the sensor.
So you say all the flow, you mean the volume of fluid that passed
the saline
from...
bolus goes in and dilutes evenly pretty quickly. Certainly after filtering through an oxygenator, it's going to be well filtered, but still in bolus form.
Okay.
If you put it farther down the tubing or whatever, you would have a wider, flatter curve, but it'll still pick up however many cc's are going through it.
Gotcha.
So I have a follow-up to that. So the problems that you see with measuring pressure, I think your point was pretty, pretty shocking. Depending on where the clot is, that you could have no pressure changes at all. So do you have the same sort of concerns with depending on where the clot is, or it doesn't matter because any part of it that is clotted is going to have the same typical effect on your saline bolus?
Yeah, depending on the degree of how evenly it forms. If you remember the first one I had, it was the only one I saw like that. It's just a smooth, even pad of soft clot, and the pressure climbed, and I thought, wow, that's very nice. That was about the only one I ever saw like that. Yeah, and some of the more progressive units that I've talked to that are actually rinsing them out, it's more of an anomaly than normalcy. So the nice precision linear rise is not going to happen.
But with the dilution measurement, you're going to have a response of that there's clot no matter how the clot is positioned, where it's even or it's in the corners, or that's kind of what I was trying to get at. Is that correct?
Oh, yeah, good question. No, you're exactly right. The bolus filters through the fluid, and then it doesn't matter what corners it hides in, it'll read the volume accurately.
That's been consumed or that is no longer there.
Right, not available.
The liquid volume that's no longer there, right, available because of the clot.
Exactly. Yeah. Good question.
And that makes good sense to me,
does.
you know, and I think that's scary because it's on the arterial side. And we think, you know, it doesn't get there, but clearly it does. And I think those pictures were frightening to me.
Yeah, good pictures. Very good.
Great
I mean, they were
pictures.
frightening to me. Mike, questions?
Yeah, it's interesting. Is we do a fair amount of ECMO with our team here in Houston, both VA and VV. Our indication for changing out the oxygenator is not so much based upon a clot, and let me just leave you with that thought for just a second. It's much more based upon whether or not we're getting circuit gases that look decent enough to continue to provide support to the patient. And the longer it goes, the CO2 tends to build up. Is that what we're seeing is clot, or is that what we're seeing? And in essence, we are still basically changing out our oxygenator because of the clot level, or because somehow there's maybe a protein layer laid down that is causing them to go down. We run our ACTs a little bit lower. We have one doc who I think would run them without heparin if he could, and but we run our ACTs 160 to 180, but I don't think within this panel that we've ever changed out an oxygenator because we saw a visible clot. It's because of CO2 retention in the patient. So is that what we're seeing, Rodger?
Well, you raised a good point. The acid test would always be, if it's failing to oxygenate or equalize what you need the blood gases to be, yeah, it's not performing anymore. But are we doing damage waiting for that ultimate late point to happen?
Yeah.
We don't know
And that's
that.
a really good question, but I think to your point, if I can elaborate on that too, that's a really good point, is if we were to measure, even though I think this end tidal CO2 is a great idea, and I think that that's what happens, it's inverse. The patient's CO2 is climbing because our ability to remove the CO2 has gone down.
Right.
And that's secondary, I think, to the obstruction or to the, to the lack of surface area for ventilation, if you will. So I think that's why we see that. Nevertheless, I think if you just use that methodology, then you still don't really know what the reason is. And I think the only way to differentially diagnose it being clot versus being just some kind of lipid or protein layer that's clogging the microporous portion of the oxygenator. If it's that versus clot, the only way to do that is the dilutional method. And that, I think, would tell us. So if you had a situation where you were seeing, hypercapnia occurring in the patient and you can't get the CO2 cleared, and that would be, to me, the time, let's test this right now.
Right.
First, let's do an end tidal CO2. It's low. So I know there's something wrong. It's not that the patient's metabolically hypermetabolic and they're producing just too much CO2. And then the next step would be do this, and if there's a volume change that's significant, well, the lung is clotting. That's the reason. If it's not, then it may be a different reason, and you may be able to tease through it. But that's the only way to absolutely say it is or it isn't a problem that is, you have a reduction in surface area from something solid. And the only thing I can think of that's going to be solid in there, if it's because I don't think any of us are squirting silicone in it during the case. At least I've done that. I haven't done that in a while. That's got to be clot.
Right.
Does that make sense, Rodger? I probably said it. I probably was rather long-winded, but I was thinking it through.
That's right on. Right on target.
I think either way, clot probably doesn't transfer oxygen and CO2 very well.
No, it doesn't transfer it at all.
Right. So, if whether it's clot or if it's a like a platelet layer or a protein layer or a problem with our oxygen transfer, we're going to change the oxygenator either way.
Yeah, but sometimes how many times have you teased through it and said,
because we're going to
we'll get it, you turn the sweep up to 10 or 12 or whatever, and we just say, let's try to make it one more day. If you had done this test and found out that 80% of or 70% or 65% of your oxygenator was filled with clot, would you wait?
No.
Okay, exactly.
Yeah, because you're thinking about not what's in the oxygenator, but what made it through the oxygenator.
Yes, exactly.
Right.
And that we don't know because we're not measuring TCD.
Yeah.
Right. So I think once you get to 20% of clot burden, I think, or I don't know what that number is. I just threw that number out there. I really don't know what the number would be, but in my opinion, once you reach 20% of clot burden, you're trending a direction that is going to increase over time your risk of thrombus embolus through your arterial circulation. At least that's what I think.
I'd agree with that. Yeah.
Okay. So where do you live?
Near Syracuse.
Okay, well, there are flights down here from there.
Yeah, they have an airport and everything.
Yeah, so we're just going to have to get you back down here I think, to give the talk on the dilution, because I really enjoyed this talk. Despite all of the difficulties, I still think it was great. And you're obviously, I mean, you really know this topic extremely well, and we just want to hear more from you.
Well, that's very kind of you. Thank you.
Sure.
I've actually got another.
Oh, you have
thing
another
I want to
question,
talk
please?
about. Yeah.
Oh, and I'm so sorry.
It's
I
not
didn't
even really a
ask
question,
you.
but I think are you doing mostly pediatrics with your ECMO, or is it adults as well?
Well, I was the clinical specialist, so I was in whatever units wanted to invite me in.
Okay.
Most of them are pediatric, but there's a lot of adult ECMO going on out there with the same problems.
Okay. So there's something that we, as our group here in Houston, when we change out an oxygenator, when we make that decision to do it, that the patient will survive that and that it's time to do that, and we're going to be staying on long enough that we should go ahead and make that investment. We see an immediate, really, and Joe, you've seen this a lot too, like a really big improvement quickly on the patient. And one thing that Joe and I have talked about is you've mentioned that you think that there's something in the oxygenator when you put a new one in that it's somehow absorbing the
Adsorbing, yes.
Absorbing.
Adsorbing, yeah.
The inflammatory.
The evil humors.
The evil humors.
Yeah.
So I mean, do you see that, or have you seen that much when the oxygenator is changed out? Is this something that, how much of it is just a new oxygenator, and how much of it is the oxygenator actually acting as a kind of a filter almost?
Mm-hmm.
No, that's a good question. The rule of thumb I'd always learned and saw was once you change out an oxygenator, another reason you want to prolong that is because the subsequent change outs kind of fall by half. So if the first one changes in a week or 8 days, you're going to need another change out in about 4 days. Rough rule of thumb, not always true, but that's another reason you want to prolong that. To your point, what I'm thinking is whatever's going on isn't just going on in the oxygenator, it's going on in the patient. So whatever chemistry is causing the oxygenator fail, that's only part of the circulation. As soon as you change out that little piece of it, then all the poisons are still in the building and are going to contaminate, if you will, whatever's the new oxygenator is going to get bit by the same bug.
Mm-hmm. Mm-hmm. Yeah, and I think that's a good point too. But I think I understand your question, and if I can sort of add to it, and maybe this will get you thinking in the same direction, Rodger. So, have you done much work or reading on plasma adsorption therapy or hemopurification, where they use those big plasma filters and they run it through like a charcoal media with various different charges on it to try to remove the protein-bound inflammatory mediators? Have you seen much of that, like the MARS system, molecular adsorption therapy stuff?
I'm not firsthand familiar with that. No.
Okay, so basically, I think what we see is that we have a patient who's been on ECMO for 5 days. They look okay. They might have been septic, or they may still be septic, but they look okay, but they don't look great. And the oxygenator is kind of starting to degrade, and we just make the decision we're going to go ahead and change the oxygenator now. So we change it. And as soon as we do, the patient just seems to look better. After it takes a little bit of time, maybe an hour or so of being on the new oxygenator, maybe 2 hours, and they kind of start to perk up a little bit. Now that doesn't last. They kind of eventually go back. And there are filters out there that are made of various different materials. There's polysulfone, and there's some kind of polypropylene. It's called M69, but I can't remember what it is. But there's all various different kinds that are designed to have inflammatory mediators adsorb or stick to them to remove them. And you run these filters until they clog up, not clot, and then change them, and you use that as your clearance of all these evil humors. And an oxygenator has a whole lot more surface area than do these little filters I'm referring to. So the hypothesis is that when we change the oxygenator, we sort of clear a portion or enough of a portion of the circulating inflammatory mediators onto the oxygenator, and that's why they look better, but then kind of trend back down to where they were over time. Is that kind of what we're saying?
Sure, I'd forgotten about the other technology you were telling me about, but yes, that is definitely right on.
So do you see, have you seen that in your practice?
No,
Or your
that's very
experience?
interesting. Yeah.
No, okay, so you haven't seen it. Now, the other thing is, to the point, and I understand your change-out's a half and all that stuff. Of course, I believe in changing the oxygenator circuit and everything else at 5 days, whether it needs it or not. But that's based more on what I recognize, and I may be onto something for the wrong reason. I'm not sure. But based on everything you told us today, I strongly suspect that changing the oxygenator, even one that has extended durability with the PMP fibers and stuff, probably should be changed because there's more clot burden in it than we ever really realized. But especially if it's a square oxygenator, but a rectangular oxygenator, I understand, or cylindrical rather, has the same potential in maybe fewer areas, but it still exists, is these dead spaces, these spaces of low velocity where you're going to have clot develop. And so if you have a patient who's septic and you get clot in the corners or you get clot in the various ridges of a cylindrical oxygenator, it's going to be infected clot that cannot be treated. So you're treating the patient with antibiotics, and yet you have this ECMO circuit on day 8, day 9, day 10, day 11, day 12 that has this clot in it that's infected, so you never really clear the infection from the patient because you just keep giving it back to them. And so I believe, like, nurses change your IV lines every 48 hours or 72 hours.
Well, if it's a central line, it's usually 7 days.
Every central line, 7 days. So, but your normal IVs you change every 48 hours. So split the difference and say 5 days. Maybe we could say 7 days. I feel like it just needs to be changed. I don't think you should leave a circuit with all of that potential for having stagnant, now coagulated blood in it for 20 days. I think, to me, that makes no sense. For the reasons of infection, not necessarily for the reasons of the clot. But now, after this discussion and incredibly great lecture, I think that I'm onto something, but for a different reason. Because based on what he's telling us, I think we have a whole lot more clot than we ever imagined. We just simply don't know.
Yeah, it's a good idea from the standpoint of, changing out a whole circuit. If you've got a lot of inflammatory response mediators floating through, then the more of the circulating volume you replace, the less of it would be retained.
Yes, that's true. That's what I think. That's what I think anyway.
That's
So,
interesting.
does that scare you? Have you changed? Are you reconsidering whether you want to move down here or not based on all of that?
No, not at all. I love this stuff.
All right, well, come on down. Okay, you can do this all the time. All right, anybody else have any further questions, comments? Rodger, would you like to make any final comment? If you want, because I've still got to give my talk, and we'll have an open discussion later. You're welcome to call in or re-Skype in if you want, or it's just in deference to your time. I thought we'd have this discussion now. We're sort of off schedule, but we had those other issues. So I don't want to keep you longer than you need to be kept, and I just appreciate so much your generous time. But you're always welcome to listen in your car, call in, whatever you want on my next talk.
Well, that's great. Thanks so much, Joe.
Thank you too, Rodger. Good talking to you. I'll give you a call back later on this evening too, if it's okay.
That's fine. Thank you, everybody.
Thank you, sir.
Thanks, Rodger.
Bye.
Bye-bye.
Whew, we made it through that one. Whew, Lord have mercy. Okay. Well, we're still on?
Yes.
Oh, shoot. Okay. Oh, sorry. Okay, everybody. All right. So let's go ahead and throw my slides up, and I'll just get right into it. Does anybody need a break? Or you just want to press on and get through this? Let's go. Let's press on and get through this. Okay. So let's go. Okay. So my talk is actually on an algorithm for deciding what type of ECMO we should, what type of ECMO you should choose, VV, VA, or whatever iteration of it. So let's go to my next slide. Oh, here I have it. Never mind. I'll do it. Yeah, there you go. So here's the patient. Patient is a 26-year-old female. Now, Patrick, you are barred from answering anything.
Okay.
So 26-year-old female,
Is this a
27 weeks gestation, severe preeclampsia. The EF is 20% by intraoperative TEE. The SaO2 is 84% on maximum ventilatory support. The patient is in fulminating pulmonary edema. There is a plan to do an emergency C-section and go on ECMO pretty much at the same time. How do you want to cannulate this patient and why? Tammy?
Pass.
No.
Hard
Photo
pass.
friend? Okay, Mike?
VV.
VV. Why would you choose VV with an EF of 20%?
That's to me, that's due to other situations that going on ECMO and oxygenating the patient would help take care of. I think VV.
That's your thought?
Yeah,
Okay.
that's my thought.
Miss Kim?
I'm thinking VA. I'm going to go against
You want to go VA? Okay,
I'm gonna
going
go
against them. All right. Why? Why would you choose VA?
the heart failure.
The heart failure. Okay, that's good.
Bold.
Miss Tammy?
I have to commit.
You have to commit.
There's only two. You're
A or B?
yeah.
No, you can go VVAA or
I'm not doing-
VVVV.
I'm not doing that.
Okay, so you want VV or VA?
I guess I'm going to lean for VV.
Okay.
Same
For the
thoughts
Same
as Mike.
reasons as Mike?
Right.
Okay. So when I first heard about this case, I was like, you're doing what? No, you need to go on VA. I was with you on this one. But, so is anybody out there, anybody call in? You could win a PerfWeb cup. Yep. We had one that was up here today that was pretty nasty, but I don't know who's that
clean
was.
one.
Yeah, you
That's
get it.
from the last
You
PerfWeb.
get a clean one. I didn't use it. It wasn't mine.
It wasn't me. I think it was John.
It looked like somebody spit in it. It looked like they were chewing tobacco.
No, it looked like old coffee.
Old coffee. Okay,
It was John.
pretty nasty with creamer in it. Okay, so the answer. Patrick, what's the answer?
VV.
VV. Why VV? And Mike hit this on the head. He's absolutely right. So this is a very important algorithm that everyone should have. You can get it from the ELSA Red Book. You can download it online, but you need to have this algorithm with you at all times, whether it be in your head or whether it be on a card. So if you look at the algorithm, if you have, and we're all not worried about the right side, the right side of this thing, just if you have refractory hypoxemia and a Murray lung score of 3 to 4, and you are in either cardiogenic shock or without cardiogenic shock, you have to follow the pathway. So let's say it is with cardiogenic shock because she was certainly in it. Then you go down the algorithm, all other heart failure. Well, she doesn't really have any reason to be in heart failure. But is the cardiogenic shock secondary to hypoxemia? And this is where the clinical decision at the time, when they told me they were going to be initiating VV ECMO, I literally was like, no, don't do that. Don't do that. Somebody say something. Nobody said anything. And at the end of the day, Patrick, Nate, Dr. Matoyer, we're all 100% correct. So they put the patient on VV ECMO, and the patient did great, and it all went well. And if you look at that algorithm, it's very simple. Hypoxemia, you either have shock or you don't have shock. If you do, then is it due to you have heart failure for another reason. Right. And there was no reason for this young 26-year-old to have heart failure. She didn't have a history of it. And so the determination was it was due to hypoxia, and the patient was put, as you see on the arrow, on VV ECMO, and it was the appropriate thing to do. In the case of all other heart failures, the other side of that is veno-arterial or veno-arteriovenous ECMO. So you can either do VAV or just straight VA, and would be appropriate. So VA for the circulatory support, VAV for the circulatory and pulmonary support. So you'd be combining both. So just very quickly, VV, it's so easy to do. I'll just very quickly going over these slides, not going to spend much time on it. So that's one methodology, double cannulation, one in the femoral vein, going up to the high inferior cava, one in the right IJ, going to the superior vena cava. You get a whole bunch of circulation through this, but it does work, effectively if you have any lung capacity at all. And I'll tell you this, turning the flow up makes it worse, turning the flow lower makes it a little bit better sometimes. So, when you don't get the result you want, turning the flow up doesn't necessarily help. It sometimes makes matters worse. There's these techniques where you can see the cannulas are being put in at different lengths. The access catheter and the return catheter are the same type of catheter. One's put higher, obviously the return, taking advantage of the normal flow of the venous circulation back to the heart, but you'll still suck some of that blood down. And then you can see there using the typical method that I showed you earlier, the femoral jugular configuration. This is the Crescent. It's the competitor to the Avalon catheter, and as you can see, it's a little bit longer and the holes are a little farther apart, so you get less recirculation theoretically. We have used it and we have had, I think, good results with it thus far on the cases we have used. We used it at St. Luke's on the cases there.
I'm trying to remember which patient that was.
It was this one.
Oh, on this girl.
Mm-hmm.
Oh, okay.
We used it on this lady. Yep,
Oh,
yep.
okay.
So we had switched to the Crescent over there. We're trying to convert all of the places to it, but we're slowly getting there because we had to use up our stock of the Avalons.
Right.
It is, as Rodger had mentioned, it is rather expensive. It's less expensive barely than the Avalon, and that's only because everything comes in it. You don't have to buy separate insertion kits. And Avalon is kind of weird. You buy the cannula, so you buy a 27 and a 31. We're adult. That's the sizes we're going to use. But you have to buy a insertion kit of 5. And so your insertion kits get used unevenly, and you always end up with more insertion kits than you have of cannulas. That keeps growing as you're using them. And so it's problematic for us from a business perspective. This comes all inclusive. It has the insertion kit and the cannula all together. So it's just a little more affordable. But it seems to be a really nice catheter. It works really well, and it has a real interesting shape to it, which makes insertion much easier than what you find with the Avalon catheter. They come in similar sizes and flow rates and all of that kind of thing, but a little less circulation because it is a little longer and the holes are a little farther apart. This is what he was talking about, which is the Tandem Heart Protect Duo, and this is actually designed for RV failure, but you can use it as a VV ECMO to significantly reduce recirculation because it goes through the IJ and then you're drawing from the right atrium and the tip resides in the main trunk of the pulmonary artery. So you can see that you would have much less recirculation this way, but it's actually designed as an RV support device that just happens to have this other, advantage. And so, but his point was it's kind of rough on the valves. It's a big catheter and it's not easy to put in, and it's very expensive. So the Avalon and the Crescent are, about $2,500 for each catheter. This catheter here is about $18,000. So it's a very expensive catheter because they won't sell the catheter only. You have to buy the whole kit. Which is the pump piece of it and all that stuff, except in Canada they do sell it separately, and in Canada they sell it for between $10,000 and $11,000 for each catheter. So they use it a lot for their ECMOs there. My buddy up in in Newfoundland, he uses them regularly and he really likes them. He says they work really well. Okay, so patient 2, now this is going to be a real tough one. But this comes with a prize too. Patient 2 is a 19-year-old male. He's 5'10", recently traveled to the United States from Africa. I was concerned about Ebola. He was unable to ventilate or oxygenate at all. He had very high peak pressures. His peak pressures on the lowest tidal volumes we could give this kid were, bordering on 45. I mean, it was really, really, really bad. And his white blood cell count was under 5,000. He was in septic shock, multiple pressors for blood pressure. His LV, however, was just hyperdynamic. And VA ECMO was done with 2 peripheral cannulas, femoral, both of which were, I'll add, undersized for this patient. I think it was an 18 French VFem catheter and a 16 French Opti catheter in the femoral artery for return. Flow was 4 liters with very high line. I mean, we didn't measure the line pressure, but the line was tight. The line pressures were high. The patient continued to do poorly, had severe refractory lactic acidosis. Arterial BP, however, was 120/90 on ECMO with continued max pressure support. The arterial PO2 was 300. The oxygenator was 350, but the pulse ox was not reading on multiple sites, neither hand, neither ear, nor the temporal area. Now, what's wrong, Patrick?
He's got an aneurysm.
Huh?
He's got an aneurysm coming off the arch somewhere. Maybe.
Okay, that's your answer,
guess.
and
Yeah.
you're sticking to it?
I'm sticking to it.
Okay, Mike?
This is a good one. Did poorly. I think I'm going to go back to something you said earlier. I think this guy would benefit from a different size cannulas.
Oh, clearly.
You know,
Clearly.
that would be my first thing I would do, but I'm not quite sure why he's doing as bad as he's doing.
Clearly, yes. Okay.
Yeah.
Miss Kim?
No idea.
Okay. Miss Sparacino?
Well, I'm really puzzled because his PO2 is really high.
Yes, it is. I'm puzzled too. So let me just ask the question this way. Where was that PO2 drawn from?
Oh, okay.
Right. Oh, yeah.
Yeah.
Patrick?
I guess I'm going to guess the circuit.
No, it wasn't
Probably.
a circuit. It was an APO2.
Okay.
Femoral arterial sheath.
Well, okay, so going back to my thought, I mean, they probably got from a radial.
Yeah.
Nope. It
No?
was drawn from, this is where the problem comes in.
Oh.
It was drawn from, that was the question I was
But if he
waiting
did
for
have an
everybody to ask
aneurysm,
me.
then if
Yeah.
they did draw from the radial,
Yeah.
it could have been right.
But this was drawn from the contralateral femoral artery from where the cannula, return cannula was. So how accurate do you think that APO2 was?
Yeah.
That was essentially a circuit gas
Yes, it's a circuit gas
Yeah,
from the
basically.
patient.
from the patient.
Because you're basically
Right out of the
getting it right
cannula.
out of the cannula.
Exactly.
Yeah.
You knew
He
it,
knew.
you win the cup.
Clean one.
So, real quickly, we all know what the circulatory system looks like. The real problem here happened to be this Harlequin syndrome. So we all know what it is. Your hyperdynamic LV, lungs were absolutely not working at all. Patient's lungs were gone. So there was no oxygenating this patient with their lungs. You had zero contribution from them. So we have these teeny little cannulas in the femoral artery flowing up with an LV that's just, this kid's native cardiac output, I'll bet you, was 16 liters.
And his pressures were so high.
Right.
Right.
So we were perfusing from probably infra-abdominal to his legs very nicely.
Lovely, beautiful.
And that's why that gas, arterial gas, the PO2 looked so good. The acidosis was horrible, but the PO2 was great. So finally convinced them to draw a blood gas from the right radial. And that's why the pulse ox wasn't working, because it was so low. And the PO2 was 26 coming out of the right radial. Well, we know the outcome was poor.
I do remember this patient.
You remember this patient?
I remember this patient. Yes.
So what could we have done otherwise? Well, there was clearly a thought that the patient needed circulatory support. And I can understand that. Despite having a hyperdynamic heart, they had that patient on massive amounts of pressors. Massive. To get 100 pressure of 120, I mean, it was massive. They were in just septic shock, complete cardiovascular, or at least vascular collapse, vasoplegia. Their heart was still beating really well, but they were 19 years old. You expect that. That's the dilemma right there. But you could have done VVA. That would have been a good choice. You get the circulatory support, plus you get the oxygenation on the right side. Wouldn't have been perfect, but it would have been good, better than what we were doing. We could have cannulated the subclavian artery. We could have done VVA. We could have tried that. Two venous drainage and one arterial would have given us a little more flow, but you need bigger cannulas to do that. I mean, there's a variety of things we could have done. We could have done VV-AV. We could have put 2 circuits in and done VV and VA. We could have done anything other than what we did.
Did we also consider central cannulation on this guy?
No, they didn't. No, they never considered central cannulation, but they eventually decided to take him to the operating room and try to convert him to VV.
Right.
But we were not, that's not part of this lecture.
Right.
That's part of my nightmares. So we don't lecture about my nightmares.
Fortunately, I skipped that part.
I know. I remember that.
That part.
Yeah, exactly. So, I've said it so many times, that VA ECMO with peripheral cannulation for isolated pulmonary failure is absolutely,
it's useless.
It's I don't know how else to say it. It's idiocy.
It's useless.
Absolutely. Now, VAV, look, I want the circulatory support. I don't think he's going to get better just with oxygenation. We need circulatory support. Fine.
Right.
Do VA or VAV or you've got to do something to recognize that if you're going to peripherally cannulate this patient, you have to do something to oxygenate it, because that syndrome of north-south, harlequin, dual circulation, whatever you want to call it, is very real. And you also have to be able to know your circuit and understand the just basic anatomy, that I'm drawing the blood gas from the contralateral femoral artery where this cannula is flowing 4 liters in, and my PO2 is 350, and you're like, look, it's fine. No, it's not. You've got to draw it from the right radial. That's the most distal point from the heart that's feeding the head. So if your right radial, whatever that is what's in your brain.
That's the true measurement.
That's the true measurement. Exactly. So just one of those lessons. My lecture's kind of like, think about it. Okay. Don't be this guy. I just said it. Never use VA ECMO with peripheral cannulation fem-fem for pure pulmonary failure when there is no LV dysfunction. But if there is LV dysfunction, I need to add to that slide, do something for the LV dysfunction, but don't just depend on peripheral fem-fem VA ECMO for pulmonary failure, if that's a problem, regardless of whether you have also LV dysfunction. You've got to treat both separately in some way. You can do it in combination, but you've got to treat both problems, not just one thinking you'll treat both. It's kind of the opposite of the case you did that won you the Crystal Heart, which was a big honor, I think, and we're proud of you for that. But in that case, single VV ECMO was the right thing to do. Because, my first thought was, no, you need VA because you need the circulatory support. But you really didn't, because her LV dysfunction was because of her hypoxia. Whereas in this case, your LV's young and it's just beating, his heart's beating like crazy. And his problem, although that was a problem, but the oxygenation problem compounded it, and it complicated matters that you have to treat both of them, or you're going to fail, right? So now another problem you get with peripheral VA cannulation is this. You can see that the intraventricular septum is severely displaced over to the left side. This is what it looks like when you put an impella in, which is now going to decompress the LV, and you can see the impella coming in through the valve up there. Let's see, right over there, right there, coming in, right down there. So that's decompressing the LV, and you see how the intraventricular septum has come back over to the midline where it needs to be. So that's always good. You got to worry about clot. You got to worry about clotting off your LV. That's a problem too. So, but anyway, that's the idea there. But there are other ways to deal with this. Here's a really good talk, I think, or a good slide. VA ECMO with peripheral cannulation and LV wall stress. You can see with the line right here that as you're on VA ECMO and you increase your flow, you see LV wall stress going up significantly. When you put either in the tandem heart or you put the Impella 5.0, you can see LV wall stress comes way down. So this is basically an empty, decompressed LV. But if you don't have that and you have LV, your LV is not pumping, you're going to have some level of aortic insufficiency and filling on the left side that's just going to keep filling that heart until it gets very distended. And of course, when it gets distended, LV wall stress is high. You know, you don't get very good coronary circulation. So now you're taking a heart that's sick and you want to recover it, and you have it on VA ECMO, and it's just getting sicker and sicker and sicker. It's not, we're helping the brain and the body, but we're really not doing much to really recover the heart. We're hurting them at that point. So you got to fix it. But you can do it different ways. You don't have to use an Impella, though the Impella, I think, is a good option as an LV vent. And in some cases, it's a good option, I think, for just circulatory support on its own merit. Though I think it's somewhat tricky. It's extremely expensive. It's kind of finicky in positioning. And I'm not sure if it's really a good long-term option. I'm just not really sure. So now you can win a prize. Somebody here can win a prize, okay? Take a look at this picture. And I'm going to just go through it with you, okay? Because I want to be fair. Everyone knows what blue means, right? Blue means venous. So this is an access line. It's coming down like this. And there's another access line right here. So this line and this line are wide together going to the inlet of the pump down there somewhere. And then the return is this line going into that femoral artery, and this line going into that femoral artery. So it's a multi-part question, multi-part test. All right, somebody's going to win this prize, and I want to give it to you. I really do, but it's a super secret. It's not a cup. It's a real prize. This is a super secret prize, but it's a real prize. Anybody wants to call in if you think you can answer these questions, all right? I mean, we want to be fair to everybody. The question I have is, what do you notice odd about this line in particular? And I'll make it easy for you. I'll give you a hint. That line right there. What do you notice that's strange about this line coming into and mixing with this line?
It looks
It's
arterial.
oxygenated.
Yeah, there's
It looks arterial.
VA, and then you get an artery and a vein
But okay,
mixing together.
So that's very good, excellent. So now the next question is, where is this line? This is in the femoral artery. That is in the femoral artery. This is in a femoral vein, and I'm giving you all the clues. There you go. So I mean, I'm not even trying to hide anything from you. Where is it? No, it's not in the air.
Crickets.
Dare? What does that mean? Dare.
Which one are we answering?
This line
the
right
left
here.
leg or the right leg?
This one right here.
Okay.
See my arrow?
Where is that going out
Where
of? It's
is-
out.
No, where is it pulling?
Where
it's a venous.
is it? Where
No,
is
it's not.
it?
It looks arterial.
Yeah, but it is venous.
Okay.
It's recirculation happening. But why?
So you gave the answer.
So you think it's that? Okay. Is that your answer?
Yeah.
Okay, no prize for you. Who else? Anybody? Come on. You got to get this.
I don't have a good answer.
I love this
I've got
slide.
an answer, but it's not a good answer.
Well, what is it?
This is VAAA ECMO.
No, I just told you.
Never heard of it before.
I just told you. It's in a vein. I even told you the thing's in a vein.
She said recirculation, and
what do you
it doesn't
think,
look like
Mike?
recirculation.
It definitely is in the vein. But I think what we're seeing there is.
Here, you want the thing, the arrow?
One of them is the cannula that goes all the way up to the top. The other's in the small femoral.
Okay, so you think these are both in femoral arteries?
No, I think one's in femoral artery, one's femoral vein. But I think
So you think this one isn't in as far as
It's
I
advanced
think
too
that
far?
one is advanced
It's-
way up to the top to the
Yeah,
heart.
it's advanced
this
too
one's
far.
advanced all the way up to the heart?
Yeah,
Okay.
I think.
Okay. You had a different idea. No prize for you either.
Oh, man, last chance.
Last chance. All right, come on. You got to get this. Somebody. Katie.
Oh.
Come on.
Oh.
Somebody can win a prize. You want to call it in?
It's a tough question.
It's a tough question. It is. It's a tough one.
I told you it was advanced too
Well,
far.
I know it was up too far, but I didn't know it went through that.
really
So
up
it went
there.
through.
So
wouldn't
instead of
expect
using
that.
an impella
Okay.
to decompress the left side, you put a line up through the vein, go transeptal from the right atrium to the left atrium, and now you can
I
decompress
wasn't
the
thinking
left
that at
side.
all.
People do that?
Yes, people do. You see the drawing, don't you?
How do they make the hole in the atrium?
You do a septostomy. You use a needle, or you use, there's another device out there. Huh?
Percutaneously?
Yeah, you puncture a needle through it. Yeah,
all right.
percutaneously. And there's a device that uses RF, radio frequency waves, to actually cut through. So a lot of times when they do these needle punctures, because transeptal approaches for things is common.
Yeah.
They do it all the time in the EP lab. But when they use a needle and push through, sometimes it will tear the septum. You'll get a tear, and it's hard to close that then percutaneously or with like a atrial septal defect closure device.
Yeah.
And so they use this other device, and I can't remember who makes it now, but it goes up and they use RF waves and they puncture through with that, and then they're able to go in and dilate it and put a catheter through. And then you hook the catheter up to your venous, and you have a left atrial drain, so you decompress the left side while you're on ECMO.
We had no chance of winning
man's
anything.
impella?
Poor
From the
man's
beginning.
impella. That's right.
From that
That's about a $60, $100, $120 device versus
Really?
a
Oh, wow.
$35 or $28 or $35,000 device. So you got to think about that. And of course, we all know what the cold foot looks like, and that's we saw the side port on that right there, sitting there right here, and then going into the SFA and feeding the foot. So cold foot, and then you can make it look a little bit better. So there's some of our resources that I'd like to see you take advantage of that we have. Of course, NurseWeb is coming up pretty soon. We're also going to have ECMO training and for ECMO specialists with nurse ECMO specialists, respiratory therapy ECMO specialists, perfusionists who may want to also attend this class. It's going to be approved for Category 1 CEU, CNE, and also whatever I guess the iteration is for respiratory. You want to talk about that a little bit? Talk about our ECMO course and
You
kind of where
just
we are with
did.
that? Well, you can elaborate on it. So you're the education director.
Yes,
So you're
I'm
director
the
of education.
I'm
yeah.
director of education. So we are developing a course that goes through all of the curriculum recommended by ELSO, and so we're looking forward to starting up and getting rolling.
So we're going to get it. The CNE is going to be coming from TNA. Is that right?
Yes, from the Texas Nurses Association.
Very good. So
Yep.
be looking for it online. We'll
Yep.
send some notifications
Yep.
out and that kind of thing. Mike, you're going to be
Yes.
one of our instructors. Patrick,
Absolutely.
I think you
Yep.
signed up to also be. Tammy, I signed you up to be one of our instructors.
Thank
of
you,
course, Katie's. I am too. She signed me up too.
Yeah, I
Katie, of
did.
course, is the
I did.
director, and she gives some lectures. So that, and with that, thank you. And any questions? So we could just go to questions and see if anybody has any questions for me on my talk.
it's just amazing how many different ways you can hook things up. And I think
that's true.
It really is. I mean, there's a lot of different accesses, and you just got to find the one that really works the best to provide what you need.
Yep.
And the thing about it is that there's been quite a few times that we've done VA to start with, but as the heart comes back, we realize now VV is the more appropriate, and you make those switches based upon what your patient needs.
Right.
And because for one part of it, it serves its function, provides the care it needed at that point. Now you're on, as you mentioned earlier, you're now on to something else. You got to treat what the patient needs.
Correct.
And so get the appropriate circuit for the appropriate patient requirement.
Well, I think that goes back to really understanding what you are providing. Because if you don't understand what you're providing and what the patient needs you to provide, you can end up doing more harm than good.
Clearly.
Yeah.
Clearly. I think that's it. I think that really understanding the circuit. You know, look, I mean, we're perfusionists, right? But, I mean, I know guys, you know, I think you do too, who are great. I mean, they're really good perfusionists. They've been around for a long time. But they really don't understand ECMO because they never did. They didn't do it. But they do some great perfusion cases. They're really good perfusionists. But ECMO is such a different thing. And you really have to understand what the circuit's doing.
Right.
You
Well, I
know,
think
it's
that's-
not like central cannulation, heart-lung machine on bypass. You know, we got that. Gets a little different when you got these cannulas stuck in these different places. And what are they really doing?
Right. Well, and I think it is more a big picture too for the people caring for the patient in the ICU. It's not just perfusionists who really need to understand it. You know, a lot of hospitals are offering ECMO now because it's the thing to do and it's going to be easy. But if you don't have intensivist and hematologist and infection control and all these different people.
Cardiology, pulmonology.
Right.
But I think too, you know, and we may be getting off topic, I hope you don't mind, but the thing is, you need a team. You got to have a team, and the
ECMO
team has to be
team.
cohesive,
Right.
number one. And number two, you have to have a physician, so somebody who has clout, some power that can say, this is what I want, who is the director of the program.
Yeah.
That, you know, the pulmonologist, the intensivist, the cardiologist, whomever it is, can manage the patient, and it could be one of those people is the medical director of the ECMO program at any hospital, and they should have absolute power to be able to say, got to stop. This is not. This is no longer the right thing to do, and we got to call the family, and that's it. Because too many times that happens where it languishes and goes on and on and on, and you're torturing people. But then on the other hand, there's people who don't want to put the patient on ECMO, and they're getting referred for it. And this person, based on their experience and understanding of ECMO, is saying, what are you waiting for? Put the patient on ECMO. You have, and how is the protocols going to be done? Look, we treat with albumin. This is what we do. This is our protocol. Because you get this new physician comes in, oh no, albumin's really bad, and we know it's not. And then we have to go through that whole process again of having a difficult run with no volume, watching the patient blow up like Jabba the Hutt, and you're just, you know, or Michelin Man or whomever, whatever, and you're frustrated because now you've got somebody else wanting to do it their way. You have to have a system and a protocol, and people need to follow it if you want to have a successful program. Not just a bunch of Sesame Street kids and everybody does things their own way.
Right, depending on who's on shift.
Right. And then you got that problem, shift changes and weekends and whatever it may be. So you need to have a strong leader.
You have to have a structured committee with someone in charge who is able to make those decisions, and who also, this team needs to come together and write protocols that are followed as a standard.
Yes.
And
then when you get curveball patients, you're like, well, you know, in this case, you know, but let's discuss that. Let's just, you know, this is not a dictatorship with new dictators every 12 hours.
Right.
Therein lies the problem.
Right.
So every time the new dictator shows up, they want it their way, and it's not what we were doing. And there's no continuity, I guess would be
Well,
the
and
word
don't you
that I'm
think
looking for.
no one feels responsible too if you're in a situation where the patient is not improving, is not going to improve? No one wants the responsibility of saying this is the end because there's no structure to who's supposed to make those decisions.
Right. Or this patient needs to get shipped out.
Right.
Start the process. What does this patient is going to need a transplant. This patient is going to need a long-term device. This heart will never come back. We can only provide this patient this much. If this is just a waiting game, we have everything this patient needs, and we can treat this patient effectively, keep the patient. But when you don't have the services to give them what they need, stabilize them, and get them someplace else.
That's the most frustrating, is because you've now decided to keep a patient maybe long-term or maybe just a few days because you haven't figured out that they need to go ahead and transfer, and now you've really hurt that patient's chances of recovering at a center that could have helped
potentially
them.
by waiting, by delaying.
By delaying.
Right, by delaying. But so you have to be able to get those, what's the game plan? What do you call it? You call it what is it called? The treatment plan.
Treatment plan. Okay.
Yeah. What's the treatment plan for this? But you're the nurse here, so I'm trying to learn more nurse language.
Oh.
Huh?
You were speaking nurse.
I was trying to speak. Yes. Yeah.
Speaking.
Yeah. I'm doing one of those. What's that called? Babble. I'm doing Babble. Nurse. That Babble is a language. Babble nurse. Well, on that thing, where you can learn Spanish, or it used to be called something else. What's that thing? Even Google has it now. The Google Translator. You can pick English to nurse.
Duolingo.
I'm gonna have to look that.
Yeah, it is there. It's there. It's on the Googles.
Yeah.
On the Googles?
On the Googles. All right. Well, I can't think of anything else.
I think that last question with the transeptal, cannula was unfair. We had no chance.
File the protest.
I do want to know something about that. Why was there a distal perfusion catheter in only one leg, not the other?
In that patient?
In that patient. Don't they put them in when they initially insert the cannulas? Or
yes.
No, they actually had two. They had two arterial cannulas. So that patient was on veno, left atrial, arterial.
Yes.
She's saying, why do you have to recirculate the leg that has the vent and the arterial access?
Right, the left leg
had... leg wasn't cold.
Yeah.
Might have been bigger vessels, put up higher. If the toes ain't black and it ain't cold, you're not going to put that SFA line in unless you have to.
But do they not put that in
Some places do. Some places do it as a standard of care in the beginning.
Yeah,
Okay.
Some do.
Yeah.
But usually they just wait to see if the foot's going to be cold.
It's like, why put it in one side and not the other?
Yeah.
No pulses on one side and pulses on the other.
Yeah. Okay.
So, or flow by Doppler or whatever. The foot's warm, this foot's cold. Yeah. I've seen it where both of them have the SFA line, the distal perfusion catheter in. I've seen it that way too. But I've seen it where there's been none. I've seen it where there's been one side or the other, or both.
As far as vasculature is concerned, symmetry is not an absolute term.
That's true. That's absolutely true. One femoral iliac system might be, 5-6 millimeters bigger than another one. Yeah, that's possible. Okay, well, I think we had a really good time.
I did.
And I want to thank, despite multiple. So, and hopefully we won't have them tomorrow. So tomorrow, what are we talking about tomorrow? Somebody bring that up? There it is. So tomorrow we're going to, Katie Kim, Advanced Hemodynamic Monitoring, and Tammy Sparacino, Non-Invasive Cardiac Output Devices. I think it got mentioned today, right, in Rodger's talk. And then a lively discussion, and it looks like we've got Kimberly Sperlin wants to come up here. So it should be Kimberly, Tammy, Katie, and me, unless either of you want to come. You're welcome, of course, to come anytime you want. No need to commit. If you want to, it's the offer's there.
I may be getting ready to watch an ECMO.
What?
Are
you serious?
We have a very difficult patient tomorrow at a hospital that's got fairly high chance of going on VA ECMO.
Very good.
A weekend's looking up.
And
Take
if
good
anybody would like to
pictures.
come and work some ECMO shifts.
Oh yeah, we can talk about
Houston.
that. We're hiring. HET is hiring. So any perfusionists out there looking for
Get Rodger back on.
Roger. Or yeah, I'm gonna call him later.
Yeah.
We're gonna get him down here because that guy would be a real.
Oh,
let me tell you what that would be in
Rodger-
addition
Rodger's
to
a
this
great
team.
guy.
No question about it. Okay, well, thank you all very much. Good evening. We'll see you tomorrow, we hope, and then on Saturday. But tomorrow we'll have another great time, and we appreciate your patience today and all of that. I'm out. Peace out.
All right.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Let's start with the basics. What's the goal of autotransfusion? The goal of autotransfusion is to return the highest quantity and quality of red blood cells to patients with the least amount of waste as quickly as possible. Take a look at what goes on inside an autotransfusion device. There are 3 categorically different methods of blood processing. Passive cell salvage, which uses a Latham bowl, continuous cell salvage, and dynamic cell salvage, which is available only in the Autolog IQ. Dynamic cell salvage uses algorithm-driven intelligent blood sensing to make micro-adjustments during processing in order to recover high-quality blood fast, automatically. How does it work? There are 3 things that distinguish dynamic cell salvage. First, there's the IntelliPath bowl. One bowl size works for most procedures. That may seem counterintuitive, but it's designed to work that way very effectively. Now here's where it gets really interesting. The Autolog IQ uses an adaptive two-stage fill process to get high hematocrit with less waste. It's a little like filling a soda glass. Pour it in all at once, and you know what happens. With the adaptive two-stage fill, the system does an initial fill. It pauses briefly to compact the red blood cells. Then it adjusts the second fill speed, slower for low hematocrit, faster for high. That way you keep more red blood cells and lose less into the waste bag. The third key feature is the pulse wash. See these little indentations? They are part of the IntelliPath bowl design. They disrupt the red blood cell pack during the wash, which helps optimize saline penetration for an effective wash cycle. The pulse wash makes the wash process more efficient by adjusting the saline volume, depending on the characteristics of the red blood cell pack. Each pulse volume is designed to help minimize red blood cell spillage. All this happens automatically. With the push of a button, you're providing high hematocrit and quality packed red blood cells for the patient with just one program. You might think that this intelligently calibrated process would be slower. Not so. The Autolog IQ processing rate is approximately 3 minutes. Every now and then, you may have an exceptional case where you want to override the automated setting. No problem. Just press the setting you want for immediate override. The Autolog IQ system consistently delivers high-quality blood product automatically. Simply genius.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.